of this webinar and type in your first and last name, your email address, your organization, and the number of people attending from your coalition. The application for Healthy People, Healthy Carolinas will ask the same information, but we also want to have record of it in the webinar. We are glad that you're joining us today. Today we hope to accomplish several things. We want to explain the vision for Healthy People, Healthy Carolinas, discuss the grant expectations and requirements, and clarify any questions that you might have about the program. We have several collaborators who have been working on this initiative for several months now. The first is the South Carolina Office of Rural Health. We also have been working with South Carolina DHEC, the South Carolina Hospital Association, and from the South Carolina Hospital Association, we have represented Carmen Wilson, Lindsay Perret, Dr. Rick Foster, and me, Melanie Matney. We also have been working with the Institute of Medicine and Public Health and Eat Smart, Move More, South Carolina. And one of our most important partners is that of the Duke Endowment. And right now I'd like to turn it over to Mika Sales to give a perspective on the endowment.
Good afternoon, everyone, and welcome to the Healthy People, Healthy Carolinas webinar. Thank you, Melanie, for opening us up. And I'm Mika Sales. I am a program officer at the Duke Endowment, and I have the privilege of leading this work through our healthcare program area. I'm excited that so many of you have responded to the RFP and are interested in learning more about the grant funding opportunity. I'm going to take a few minutes just to give you a little bit of background on how we got to where we are at this point today. Many of you know, and if you're not, you're familiar, the Duke Endowment is located in Charlotte, North Carolina, and we have been in existence since 1924 as a private philanthropic organization, and we fund in North and South Carolina exclusively. And through our healthcare work, we have a commitment to improve access to care, the quality of care, and advancing prevention. So this funding opportunity, Healthy People, Healthy Carolinas, is our new approach, if you will, to advancing prevention work in communities in North and South Carolina. The effort has been underway in North Carolina for about a year already, and we're excited to be here today launching, this is kind of our launch day as we think about it, in South Carolina, and to have the opportunity to invite coalitions to join the family of Healthy People, Healthy Carolinas. So just as you all are experiencing, and we've been observing and even learning through our own grant making, that the landscape of healthcare is changing, and with that, there's going to be more of a focus on, population health, however you want to define that. I think we're looking at it as an opportunity to support or to direct some of our funding to create and to support healthy populations. And so this is one of the reasons that we've designed the funding opportunity to target, or to be the funding opportunity to go directly to community coalitions, so that we can have an effort to get as local as possible to our funding on the ground. And we are really excited about the opportunity to contribute to this space. We know that a lot of you have been working around improving health in your community for a long time. There's a lot of good work going on locally and regionally and nationally, and this is one of our best efforts to try to contribute to the good work that's ongoing. With that, I will say, as this is a new approach for us, we are also open and being transparent about what we need to learn. The work is very iterative. Particularly when we've worked with our coalitions in North Carolina, we've learned a lot about, what it takes to fund at this level and in this way, and we're looking forward to learn more about what that looks like in the South Carolina context as well. And just as one question that a lot of people have, and it may feel a little disjointed to say, we really want to fund communities and coalitions, but then also say, we have to direct that funding to healthcare entities, our hospitals. But we believe that the hospitals are integral partners to community health, and also our endowment, and Mr. Duke, when he laid out the indenture, really directed us to fund and support hospitals. So that's one of the reasons that the funding the funding will continue to directly go to hospitals to support community coalitions. So that's my spiel. Also just want to say thank you to our collaborators. About a year ago, we reached out to the South Carolina Hospital Association and asked them to, if they would consider helping us put together a group of folks to think about the technical assistance that we would offer to community coalitions. And we had direct input from the Institute of Medicine and Public Health and the Office of Rural Health. And then the team in turn reached out to Eat Smart, Move More, and DHEC. So we're glad that we have all of these folks involved, as well as the Alliance for Healthier South Carolina, to help coordinate technical assistance and provide and shape this resource to be another tool for you all to use to improve health in your communities. So I'm going to turn it over to Dr. Rick Foster at this time to talk a little bit more about the program and expectations and offerings through the funding from the Duke Endowment.
Thanks, Mika, and good afternoon, everyone. It's great to be with you. I'm very excited about the opportunity to kick off this very important initiative and funding opportunity from the Duke Endowment. I also want to start by expressing my thanks to Mika and to Mary Piepenbring and the others there at Duke Endowment for their continued progressive and innovative leadership and guidance. I'm just completing my first decade of work here at the Hospital Association and would not have been able to do the work that I've been involved with, initially with quality and safety, now with population health, if not for the support and guidance of the Duke Endowment. So we're all very fortunate in both Carolinas to have such a strong philanthropy organization helping to guide and lead our efforts. I also, again, logistically want to remind everyone, by the way we have this set up and we have a number of lines open, that if all of you can make sure that your lines are muted on your end, and please don't put us on hold. We love your music, but not during a webinar like this. We really need for everybody to be able to hear all the information so that you don't miss anything important. We're also going to ask you to use the chat box for any of your questions because it's going to be difficult for us to sort through questions coming through multiple lines. I want you to know as we go through this today, though, that we're going to be readily available to any of you that are on now or were on this morning at our first session to answer any questions you have. We're glad to have one-on-one discussions, phone calls, whatever we need to do to make sure you understand fully this opportunity, and that'll be available to you afterwards. We'll also be making available the recordings of these webinars as well as the slides, which have even been updated from this morning, available to everyone so that we can answer any questions you may have. So as that said, I'm going to move on, and please, if you have any questions, comments, or that you need to make, do that through the chat box. As you see here from a fundamental shift perspective, we're moving from just to focus on individual programs and projects to a more coordinated effort at the community level. So the idea of building coalitions that are multi-sector and multi-stakeholder to drive forward for both health and healthcare improvement efforts for all. We're moving from an environment where we have, not just limited data availability, but looking at data basically in silos where we're looking at healthcare data separate from social and health related data, to moving to ability to have more robust databases, but also being able to provide population-based data with an equity lens to communities and community coalitions in a way that you can use that for decision making and to help you monitor how you're doing to improving outcomes. We're also moving from looking at what may work to actually helping coalitions and groups at the community level understand how to implement evidence-based interventions and programs, and then obviously moving that continuum from looking at clinical care only to understanding that dynamic interplay at both the person and population level of social, environmental, economic, racial and ethnic, geographic factors with the person's health and health outcomes. All right. One of the key aspects of this program is going to be around the fact that it's explicitly stated that these coalitions need to be using the collective impact framework for moving forward. And I'm just going to assume that we've got probably a range of understanding of the collective impact model on this webinar today. So I'm just trying to give you a little bit of background with this understanding. If you're trying to bring key partners and stakeholders from both the public and private sector and the community. The collective impact model, a number of us have had a lot of experience with this. The work we've done with the Alliance for a Healthier South Carolina, which is our statewide coalition, work like with the Birth Outcomes Initiative, the Healthy Outcome Plan, even programs like Scale Down related to obesity prevention, are built in many respects on this collective impact model. And there are 5 key components, and I think these are all important as we think about how this is going to be set up. It starts out as you bring that coalition together is creating a common agenda or a common set of strategic priorities and goals as far as what it's going to take to have an effective health improvement plan for all in your community. It's followed by, within those priorities, creating a common set of measures and metrics of how you're going to really look at measuring both the processes in place, but also how it's affecting outcomes from a health and well-being standpoint for those in your community. The third core principle is around actively reinforcing alignment of work, taking advantage of the expertise of the various organizations, but creating alignment so that you don't have gaps from an execution standpoint and can have accelerated achievement of those goals and better coordination of work. The fourth is around communications and the idea of finding all various range of ways to have a strong communication plan that is effectively conveyed to all those involved so that you're staying constantly in connection and building that culture of collaboration. And finally, and very importantly, at the foundational level, is having a backbone organization to support this work. So one component of the Healthy People, Healthy Carolinas program is going to be around, in addition to having these multi-sector coalitions in place, is to make sure that you have a well-defined backbone structure that can, on an ongoing basis, support the work of the coalition. And then you see on the left-hand side just some examples of the range of organizations that are coming together. One thing I want to say as we move into the next set of slides is that we're going to recognize that we have a range of coalitions across our state that may be at various stages of maturity and already doing existing work. And so as you see here in a few minutes, we're really talking about trying to build on work you may already be doing in your community. I also want to make sure that you understand as we go to the next kind of several sets of slides, that the way we're defining community is how you define it geographically. I know in North Carolina, the existing coalitions are either county-based or multi-county based. So we're not going to define the geographic boundaries for you. We're going to allow you to do that with the partners you're working with. Any other observations as we go into this next step?
No, I think it's really important to understand some of these backbone organizations as you talk about the coalitions, and the idea there is that someone is dedicated to this work, so that you've got someone in your area. It's not just everybody coming together, but nobody actually gets the work done. So someone has to be dedicated to this work in that backbone organization. And
that's a good segue into the technical assistance that we're going to be providing to you. And we've already mentioned there's a group of partners who have been working together on a number of different fronts here in the last couple of years. And the idea was to try to align our work at the technical assistance level and create a true technical assistance hub. And these are some of the key components of what we'll be providing to each of the community-based coalitions that will be selected in this first cohort. First will be a individualized coaching, and I see that kind of coaching at 2 main levels. One is coaching you on how to effectively put in place multi-stakeholder coalitions and how to effectively run those coalitions. So that includes training around the backbone structure. And then the second major level of individualized coaching would be how to effectively do put evidence-based interventions in place and do quality improvement work, again, in a coalition type setting. The second area of technical assistance will be on an action learning session. So think about this as the learning collaborative part of this, where there will be opportunities to come together face-to-face and meet with other coalition teams and learn from each other, but also learn from subject matter experts. We hope there will also be opportunities even within this to get a chance to interact with the coalitions and community teams in North Carolina. And that'll be done both face-to-face as well as using webinars and other technology. The third area is the peer-to-peer learning. So we're really going to try to make sure, again, using that continuous communication part of collective impact, is to make sure that we're easily and readily making available to you the bright spots and promising practices that are going on within coalitions and across coalitions, so we can learn from each other and not have to feel like we're always reinventing solutions. The fourth area is around on-site facilitated visits and action events. So the team that's going to be together supporting Healthy People, Healthy Carolinas will be coming and doing on-site visits each year during the initial 3-year program. And we'll come in and be sitting with your coalition teams, your backbone organization, as well as those who are working on the specific quality improvement evidence-based interventions, and try to look at how you're doing and give you assistance directly through those on-site visits on how to best move forward with your work. And then finally, a range of virtual support and tools, both resources as related to the work you're doing, but also a portal for you to be able to submit the data that you're going to need to submit as it relates to the work of your coalitions. It's just a range of again, tools and support that we'll provide to you. And that'll be kind of where the Technical Assistance Hub component comes into play. As far as the overview of the timeline, as you heard somewhat already from Mika, the plan is in the first part of 2017 that 5 South Carolina community-based coalitions will be selected, and then in 2018 another 5. And so the idea is we'll have a first cohort and then a second cohort, hopefully with the opportunity to continue over the next several years to build a growing network, interconnected network of community-based coalitions. For each of the coalitions that are selected, you will receive up to $150,000 per year for up to a 3-year time period with an option for renewal. And I think that option for renewal is very important as far as looking at hopefully a long-term relationship between the Duke Endowment and this network of community coalitions in both South Carolina and North Carolina. The applications, which are already available, in a few minutes we'll show how to access those, will be due to the Duke Endowment no later than Monday, January 16th of 2017. Again, those are already available, and we'll come back in just a minute and talk more about the aspects of the application packet. Then following the submission of those applications, those coalitions that are determined to be eligible for consideration will get a site visit from a joint team between the Technical Assistance Hub and the Duke Endowment, and we'll actually be coming in to meet with each of you as well as your community partners to try to get a better sense of where you are with your coalition work, the level of commitment, and what specific interventions you're planning on working on or continuing to work on. And then there'll be award notification by the end of May, first part of June. After the site visits, that will go to the Duke Endowment Board for review. And so you'll know by June, and then the program itself will formally kick off with the first cohort in July of 2017.
Hey, Rick, can I just add something there real quick? This is Mika. Yes. Regarding the option for renewal, just to flesh that out a little bit, I want everyone to recognize that we are looking at this from the endowment standpoint as a long-term investment, almost akin to the Access Health Network. And so our funding, the funding opportunity is also around building capacity for local coalitions, foundational capacity to help them either grow into that backbone organization or be that backbone organization and to do all the functions of the collective impact kind of framework. And so we know that may take more than 3 years. So our sense is that as long as initial grantees are meeting the requirements in the first year and making progress, then that funding will likely be there for many years to come.
Thanks so much for that clarification, Mika. I mean, I think that, again, this is a wonderful opportunity to, again, help build the capacity in those coalitions and hopefully have them created in a way that would be sustainable long-term to implement a health improvement plan. So that gets us into the eligibility criteria. What we're looking for are committed and established community coalitions, and as I mentioned at the very beginning, we do appreciate, and this is not different in the Carolinas and the rest of the country, that these community-based coalitions are all along the continuum as far as how long they've been up and running and how mature they are. But we do want to make sure that there is an existing and established multi-sector, multi-stakeholder coalition that has broad community representation. The the next eligibility requirement is that a community health needs assessment has been conducted that has actively involved other partners, in particular as it relates to not just the needs assessment, but the action plan as far as what your plan is going to be doing, which leads to the next requirement that there is either already in place or a plan to develop a community-wide health improvement plan. And that's part of that long-range commitment. So this is more than just a group of projects you're working on, but the projects are a part of a plan that everyone is committed to. That's the common agenda again, that you're going to work toward improving the health and well-being of all in the community as you've defined it. The applicant, and I think Mika already touched a little bit on this, will need to be a nonprofit hospital, but we do recognize that we do have communities that either do not have a hospital right now or don't have a nonprofit hospital. And so if you've got a coalition in place and are interested in pursuing this, then we're going to encourage you to reach out to us and to Mika to talk about how you could best structure that to still be eligible to pursue this grant-funded opportunity. Anything else that y'all wanted to add here?
Yeah, I think one thing we discussed a little bit this morning is that though the application has to come from the hospital, that hospital does not necessarily have to be the backbone organization of the coalition.
Right. One of the things we want to make sure of is that for those who have, and again, we're saying you need to have an existing coalition. If you already have a structure where the hospital is able to take the lead as far as the applicant as well as the fiscal agent, but you've got a key partner that's serving as the backbone or a group of organizations that are serving the backbone, we don't want to make you have to make changes that might get in the way of the work you're already doing. And so that's where we're trying to be cognizant and respectful of the existing structure that you have in place with your coalition. All right, so as far as the application itself, as you see here, the request for proposals are now available at this web address. And again, we'll make all this available to you after the webinar today. And then you submit your application at the address, which is the second one listed on the slide. So like I said, you should be able to go to that site now, that first site, and look at the application. In addition to the actual application document and a budget form, which is based on the standard format that the Duke Endowment uses, there will also be a requirement for you to provide a descriptive document of your coalition, how it's structured, who are the participants of it, how you have the backbone structured, as well as any existing work you're doing. So you see here, how have you worked together in the past to implement evidence-based interventions? Obviously, we'd like for you to describe any outcomes that were achieved, any specific focus on health disparities, because something we touched on a little bit, but I think one of the key parts of this program is the explicit focus on looking at our work with an equity lens. And how will you plan or will you sustain your improvements? Vision of what you hope to achieve by participating in the Healthy People, Healthy Carolinas program, and some level of description of how other community resources will be included and connected to this work. Also, you want to go ahead and just mention about that aspect of it, Carmen?
One of the other things that's important to note is the coalition has to work toward an objective of combating obesity and or a chronic disease that's affecting your area. So keep that in mind as you go through the application process, that the work has to address one of those or both of those combined in your work.
So again, we're looking at trying to again build capacity of existing coalitions, and we realize that your coalition may already have a range of projects you're working on. But I think it was important in the first phases of this that there was a need to identify one specific area that all of the coalitions would be working on for as much as anything, so that then there's some common threads here as we try to work together across coalitions to learn from each other. I think there was also recognition that there is a lot of good work already going on in the area of obesity prevention and chronic disease prevention. What we don't want you to do is feel like that if you're working in other areas that you need to stop that work, because ultimately what we'd like to see are strong multi-sector coalitions that have a portfolio of projects that are tied back to what you've decided is your health improvement plan. So for instance, if one of your plans is around reducing obesity and the associated chronic disease burden, then it would make sense for you to have a major evidence-based intervention or interventions going on in that area. So that's the way that's been structured, and it'll be important for you to, again, to acknowledge in both the application and your coalition description what work you're already doing. Okay. As far as the expectations in the first year, so let's say you're one of the coalitions that's selected. We will officially start the work of that first cohort in July. So between July and June of the next year, if you haven't already done so, that you'll be identifying a designated coordinator. So that's the lead person of your backbone structure to lead the coalition and develop the coalition's capacity to serve as the backbone organization. A part of what we'll be doing, including with the coaching and some of the other work through the Technical Assistance Hub, is helping you build the capabilities of that dedicated coordinator and of the backbone. Then we'll be also looking at what specific evidence-based interventions you're putting into place and what work you're doing along those lines to be able to address the evidence-based interventions that you've selected. And again, this is where we would be also helping to identify resources to help you have that, to put that in place. And I'll come back to that more in just a minute. The third area of focus in that first year will be to inventory data sources available to and used by the community. So some of that will be helping you as far as getting access to data sources, but also to be able to look and see how you're using those data sources and how you're sharing that information with your community partners. And then finally, there will be a portal where there'll be certain specific data elements that you'll need to report related to the Healthy People, Healthy Carolinas program to demonstrate progress and impact. And I want to mention at this point that there'll really be two major levels of where we're going to be looking at data reporting. One's going to be at the coalition level, so there'll be some level of data around the level of alignment and commitment of your coalition, and hopefully how that's evolving, including building the capacity as well as the capacity of your backbone. And then, of course, the ground level data will be around the evidence-based intervention that you've selected, in particular related to obesity prevention and/or chronic disease prevention.
So now we're going to ask you guys to please submit any questions that you might have through the chat box, and we will answer those as they come. So we have one that someone has already submitted that says, what is your definition of coalition in this context?
When we talk about coalition, we're talking about where there are key partners from the community, ideally from both the public and private sector, that have come together to make a common commitment around improving health for whatever, again, community as you defined it. So that could be a county, it could be a group of contiguous counties, but there's what we call, another way of putting this is kind of a guiding group of key leaders from, and of course, hospital systems, other healthcare providers, schools, government agencies, local elected officials, businesses, community-based programs, just so that broad range of stakeholders. In some communities it may be not just the secondary schools, but also if you have a college or a technical school, having them in the room. And so looking at all the key organizations that would need to be present if you're really going to work on improving the health and well-being of specific populations.
Well, I have a question that might be good for Melanie or Dr. Foster. Who is reviewing the grant proposal?
I mean, Mika, do you want to take that on first? Oh, Mika, can you hear me?
Oh, here she is.
Go ahead, can you hear me? Sorry. I'm sorry. I was saying that the reviewers will be a team from the Duke Endowment and the technical assistance providers. These grants, you know, at the end of the day, will be a grant that comes from the Duke Endowment, and so that's why we are maintaining the connection to retrieve the proposals. We'll share them with the technical assistance team, and then we'll put together a collaborative group of people to review the applications and do the site visits.
And I think that'll also, I mentioned it earlier, but that'll match up with the fact that it's going to be a collaborative team between the Duke Endowment and the technical assistance teams to come and do the site visit as we make the decision on potential eligible applicants. I also noticed one that was asked this morning as well, is our matching funding required for this? And Mika, you can answer as well, but there's not a requirement for matching funding. I think if you obviously are in a coalition that already has other funding sources for your work, I would recommend that you include that in your description of the existing coalition work. And I would say that obviously longer term, the hope is that there will be other matching funding to support you long term. But as far as the initial application, there is not a specific requirement for matching funding.
There's one that was sent just to me. It says, can the grant monies be used to offset compensation of the designated program coordinator?
And I'll start, and maybe Mika, you can add to that. Is that the expectation, although we're not going to formally define this or make it prescriptive, is that you use the money that's coming from this grant to both support the work of the coalition, which could include helping to cover the cost of a coordinator and the backbone structure, matched with the cost involved in actually running your evidence-based intervention or interventions. I also want to add that the amount that's going to come to you as a coalition is focused on what the work you're doing locally. The support of the technical assistance hub and the resources we provide to you do not come out of the $150,000. That's separate, including some resources we're going to provide to you on the data front as well as on the communications front. So you're able to take that $150,000 or up to $150,000 a year and use it both to support the infrastructure you need to effectively run a coalition as well as to run your interventions. Anything you want to add on that, Mika?
No, I think that was well said.
Okay, and the next one has been, as a hospital, we're part of a coalition that's been coordinated by DHEC. We've also developed our own population health program separate from the coalition. Let's see. Is it appropriate for us to utilize the current DHEC coalition to build on with this grant? Yeah, the way I'd respond to that is I realize that there's a broad range of way coalitions may have come together, community by community. I think that if you have a coalition where you've got public and private partners already working together, and that coalition is such that you'd be able to do ongoing evidence-based interventions, including around the area of obesity prevention and chronic disease prevention, that you should build that application on the foundation of that existing coalition. We're not looking for new coalitions to be formed. In fact, what we're looking for are communities that have existing coalitions, and as long as, if there's, again, a hospital system in that community and they're actively part of the coalition, as well as other partners like DHEC locally, that's the kind of multi-sector coalition we're looking for. So I think you could build it, again, on that existing coalition, as long as you, within the application process, you describe clearly who are part of that coalition and what existing work you're doing and what you're going to focus on as far as going forward from an evidence-based intervention standpoint. And as I mentioned earlier, there's also a budget form that you would be letting us know how you plan on using that money, as well as any kind of in-kind support along with the dollars coming from the grant.
We've got two very similar questions. Can a new coalition be organized for the grant? And then additionally, how established does the coalition need to be? If this grant allows for a coalition to become established, is that acceptable?
Again, I'm going to let Mika help me, but my understanding is that the expectation is that you need to have some level of an existing multi-partner, multi-stakeholder coalition in place, and that if you're looking at forming that coalition from a new standpoint, it's not been in existence before, this program is not set up to do that.
Yeah, I think that's right. There? Yeah. Yep, can you all hear me?
Yes.
Yes.
Yes, I think that's correct, Rick. And I think, and part of that is, the reason for that is that we want to expand on the good work that's already going on. I think particularly if we're looking to direct evidence-based resources to physical activity, nutrition, and chronic disease, we know there's a lot of good work there going on. And so our intent is to really improve, expand the capacity, the reach of coalitions. And again, as I said earlier when we opened up the webinar, that the endowment is learning in this space too. So we're going to be, have our eyes and ears widely opened and brains widely open for this first cohort. And if we see that we need to make any course corrections in the second and third cohort, we will. But this is kind of where we've put our stake in the ground at this point, and that's what we've established in North Carolina as well, and we'll keep our eye on it to make sure it matches the local needs in the context of South Carolina.
Yeah, and I mentioned earlier, while this is not designed to kind of help start new coalitions, I think we'll be cognizant, just like they were in North Carolina, that you're going to have different levels of maturity, and because there are multiple layers here as far as coalitions and doing evidence-based work, I think we'll take into account, one, the commitment of the various partners to work together, and then that's even the community needs assessment, what level of already actions being taken together to address the biggest health issues in a community, as well as the fact that there is at least some experience in trying to work on specific interventions together. And so I think as far as any need, there's a question as far as, are you considering mental health a chronic disease? And I'm going to ask Mika to help with that. We've had a lot of good discussion about the fact that, when you say preventing chronic disease, that obviously we have major mental and behavioral health challenges in both states and around the country, and we know that a lot of the coalitions are working in that area. So, Mika, do you want to make any comments, and then I can follow along from there?
Sure. That's been a struggle for us, and I love that question. So thank you for whoever posed that. Mm-hmm. I think, just to be really frank, I think we are not looking at that as a chronic disease, but at this stage. We also, additionally, outside of this special program funding effort, we have a priority focus on mental health. And so we looked at how we may address that in other ways. We do, I guess I can circle back to something Rick said earlier about if a coalition is working on mental health, it doesn't mean that you're not eligible for this funding. Meaning, like, we envision that coalitions will be taking on multiple community health improvement efforts, at some point down the road. I don't know if that could be now or in 5 years. And so you could be focused on the most pressing needs in your community, and mental health could be one of them. And if you're also looking at physical activity, nutrition, and diabetes, for example, that would keep you eligible for this funding opportunity as it stands right now.
Right. I mean, I will say that as I said earlier, that there was a need, again, as part of this process, since this is new territory, to identify a specific kind of area to make sure every one of the coalitions was working on. So in this case, when we talk about obesity prevention and our chronic disease prevention, I think there's a connection there to look at those chronic diseases that are most impacted by the issues of obesity. It may also give an opportunity where I do know that in many of our communities, both urban and rural, there may actually be multiple coalitions, driven more by the specific area that those coalitions are working on. So it may be an opportunity where in a community you have a coalition that's been more focused on obesity and that chronic disease prevention effort, and another coalition working on mental health, is that you may apply through that one coalition, but as you work, and we work with you, there may be opportunities for you to create alignment across coalitions. So that's where ultimately, and this may be my one closest thing to an editorial comment, is what we'd like to see is in communities where there's a guiding coalition that then is connected to the most important work being done in your community. So ultimately is that you potentially would have a coalition that is focused on obesity and that level of chronic disease, on behavioral health, and including the drug addiction problems. And you may have another group working on, improving the health of babies and children. So it's, but that's part of that evolutionary process. And so this is the starting point, is to look at the coalitions focused more on the obesity and chronic disease in that area. There's a question about, can a city meet your definition of community? The way I respond to that is that we've left it for the coalition and the hospitals working with the coalition to define geographically what you consider a community. I know and you can help me with this, Mika, because I'm not as familiar with the second cohort. In the first cohort in North Carolina, they either were counties or multi-counties. But I don't know that there's any restriction on the fact if a city wanted to pursue and they had a coalition in place at the city level, that would be fine, correct?
I think we would take a look at it. In North Carolina, they are county coalitions. For the first cohort, there was one that was multi-county. For the second cohort, they are all single county. So I think what the analysis may be in this situation is what else is operating in that county. So that it's not a situation where there's multiple. Let me say it this way. The example that you just gave around kind of the guiding coalition and how growing into that, I think we would not want to create a funding opportunity that would create more silos in a county.
Yeah.
So we'd have to look at what else is happening.
Yeah. You did a nice job of framing that. I guess now that you've said that, I'll reinforce the fact that obviously if you had a city applying within a county that was also applying, then we'd have to look and say, is that the right level of alignment at the present time? And so while we want to give flexibility on how community is defined, we're trying to create an environment that encourages that kind of more of a collective approach within a specific area. Back to the county piece, there was a question about how a county scores on the county health ranking as far as the national comparative data. Will that affect a coalition's consideration as being eligible? The way I look at it is we're more interested in looking at what you have in place as a coalition, what are the partners and their level of commitment to work together, and what specific area you're going to focus on, and not so much about how much of a problem you are as far as ranking some versus another group. That's another place where I also think even with the county health rankings does not take into account even at a sub-county level specific populations or communities within a county from an equity standpoint where there might be gaps. And so I'll let you, if you want to respond as well, Mika, but I don't see us necessarily looking as much at where you are as far as rankings and county health rankings. It's more about the level of your coalition and the commitment to work together on specific evidence-based interventions.
Yes, that's exactly correct. We haven't used the county health rankings as a way to, strengthen or evaluate a coalition.
So one of the questions is about what types of evidence-based interventions do you have in mind to be implemented, and I'll start and then we can see if others want to add. This could be specific initiatives around preventing obesity, and I think that could be, the way I look at it, both for children, adolescents, and adults, and it could be geared towards certain parts of your community as far as that you've identified that may be more at risk for the impacts of obesity. Another example of an evidence-based intervention would be developing a pre-diabetes screening and intervention program, and again that could overlap with also looking at populations more at risk from obesity standpoint. And so or looking at the impact of obesity on cardiovascular disease, and so again targeting specific populations. I think we are cognizant of the fact that even if you take the whole realm of obesity prevention and associated chronic disease prevention, that's a very large area to focus on. And so it's almost like from the quality improvement world, that kind of overlapping series of PDSA cycles or rapid cycle improvement. As you look at your evidence-based intervention within that realm of obesity and chronic disease, as you define what population you may be targeting initially for obesity prevention or for an effort like pre-diabetes screening or early intervention to prevent cardiovascular disease in certain at-risk populations in your community.
I'd also like to note that our Working Well programs are evidence-based interventions that can be used in these programs as well.
Right. So again, you can build it on work you're already doing, like with the Working Well or Eat Smart, Move More, and that's why those are organizations that will be part of our effort. DHEC, with the work they've been doing statewide on the diabetes prevention and pre-diabetes screening and intervention, those will all be resources available to you and would be kind of fall within this scope of obesity and chronic disease prevention as far as looking at ways that you can address those. The next question is, what can the funds not be used for?
And there's a similar question here that says, are there restrictions on the funding and can they be used for buildings and et cetera?
And I'm going to defer first to Mika on this one. I know there was a question this morning about indirect funds, and my understanding is that while you can obviously use it for operational costs related to managing both the coalition and your evidence-based interventions, that there's not a separate allowance for indirect costs. And as far as like the related question about buildings and facilities and all, I'll let you respond to that, Mika.
Yeah, we don't anticipate that the funds will be used for buildings. I guess in this context, it's capital for buildings, like structures. And so we really weren't envisioning use of the funds for those types of things. And I will say that we are remaining pretty open to how the funds are used. I mean, so we have we're starting to build some evidence in terms of experience on our end about the types of things that are likely to be requested, which are staffing support for coordinators, you know, some local like marketing and communications. There may be some equipment like, you know, computers, you know, some technology that might need to be used at the coalition level. And kind of your supplies, kind of your usual suspects. We're not, we've had some internal conversations about, you know, giving really strict guidance or, you know, even guidance on if there are requests for, you know, any physical structures that might aid an EBI. But we are going to take that case by case, and so we would encourage awarded coalitions to work with their technical assistance team to route those questions to us. So, you know, here's where we're kind of really saying we may not know everything that may be needed to support the coalition. We don't want to put guidelines in place that will limit what you all may need to do, and so we'll be open to having that conversation during the funding relationship.
And I would say even during the application process, if as you're working on your each of you working on your budgets, if you have questions, you need to let us know. We'll try to provide as much guidance as we can. But I think it really is around the cost of running your coalitions, which includes the infrastructure, both from a management standpoint as well as from a data standpoint, as well as the cost of actually running your evidence-based interventions, which may include developing resources and tools and having meetings and other kinds of educational activities. There are a couple questions related to backbone, as far as qualifications for a good backbone organization, as well as does the coordinator have to be employed by the hospital? I mean, I'll answer that second one first. While again, the nonprofit hospital needs to be the applicant and the fiscal agent, the coalition can choose whatever entity that's part of their coalition to be the backbone organization, and where the coordinator comes from. It does not have to be employed by the hospital. So you could tap into one of your other partners from either the public or private sector, and then you would just need to work out the details of that arrangement and then how you would handle that from the budget standpoint to cover the cost of that coordinator. As far as a good backbone organization, I think that's part of what we're going to be doing, is helping each of the coalitions to develop that capability based on our own experience and from other subject experts, and then looking at how you can develop that backbone structure. I think that the key is, as much as possible, you need to have dedicated staff, and I say staff that can be one person or more as you go forward, and then there needs to be some, I think, defined parameters of within whatever organization that you choose to be the backbone, that they're focused primarily on coordinating the activities of your coalition, as well as working with the teams that are involved with the evidence-based interventions. And if they're having to do that along with a lot of other duties, it's going to be difficult for them to be effective backbone organizations. So it's a combination of those who have experience with running coalitions, but also a structure that makes sure that person or group has the time and resources to be able to actually effectively run the coalition and make sure you're connecting all your project work. And then one other question here is on speaking more to social determinants and its place in coalitions. Great question. I think what we're looking at here is to say that making sure that your coalitions, whether you're looking at the data or making decisions on your interventions, are realizing that the impact of social, environmental, economic factors on your major health problems in your community. So again, using obesity and chronic disease is starting to look at upstream solutions as part of your work. So as an example would be, as you are working in the area of obesity and chronic disease prevention, to say we've got some communities that one of the risk factors is that they're in a healthy food desert. So building, food hubs would be an upstream solution that could be part of the work you're doing, along with education and specific interventions at the individual level for obesity reduction, or looking at other factors that could contribute to obesity and the earlier onset of chronic disease. So in the schools, working with your local schools to ensure that there is healthy nutrition being available in all settings to your students, as well as opportunities for physical activity. Those kinds of efforts that are more what I call upstream efforts rather than actually treating the obesity and the chronic disease. How you would go about going into certain communities and doing screening for prediabetes or for risk of cardiovascular disease, how you would interact with community partners to do that, and acknowledging those social and environmental factors that may be the biggest contributing factors to the health problem in your community. Any other? Where else? Did we miss any others?
I think those are all the questions we have. I am going to turn the slide over to Melanie Matney to close us out.
Well, wonderful. These were a great set of questions, and thank you, Mika, Rick, Carmen, and Lindsay. You've done a wonderful job in arranging and carrying out these webinars today. For those of you on the webinar and the call, please remember to type your name, email address, organization, and number of members attending the webinar into the chat box of the webinar. If you haven't done that already, it is asked on your application, and it is a requirement to at least listen to the webinar either live, or since they have both been recorded, they will both be available. And I'm going to take just a second and make sure that everybody puts their phone on mute while I have these last important announcements. Also, make sure that you submit your applications on or before January 16th. I know the application link is complicated. It is also available directly in the request for applications if you have not seen that. Make sure that you send any questions that you have to Mika, and her phone number and address are on the webinar slide. And if anything, you also are welcome to send questions to Lindsay, and she will triage the questions if she can't answer them directly to get them to the right person to answer. Also, I mentioned the webinar is recorded, and you can contact Lindsay to have that available to you. Does anyone else have anything else? Mika, would you like to close out the call?
Certainly. Again, we are really elated that
Sorry, Mika, something cut off there. We heard you're elated, but we don't know what you're elated about.
We're elated that it's almost a holiday. And that, yes, and that you all have this much interest in this grant funding opportunity, and we look forward to meeting and hearing about your work. So thank you and have a great holiday.
Yeah, let me also quickly that if you only join by phone, we know some people may not have been able to join through the webinar. Please email Lindsay and let her know that you were on. Because again, we want to make, since there's a requirement for any coalition that's going to be submitting an application to have at least one person on this one of the webinars. We know that you may not be able to get on the webinar to tell us you were on. So just email Lindsay if that's the case. And I think somebody was trying to ask a question.
Yes, I could not get into the chat box to let you know that I was here and ask a question.
Well, if you could just send us email to Lindsay L. Perret at PERRET@SCHA.org and just give us your name and who you're with.
Okay, thank you.
We'll record that. And I hope everyone has a very happy, safe Thanksgiving holiday. Thanks very much.